Dr. GVK. Thank you, Anjana, for setting that stage. Fantastic about what actually happens in our country. We know that obesity is the mother of all NCDs, and I've been fighting this excess fat for the last 2.5, 3 decades, and I've been yo-yoing, and it's tough. It's easier to control diabetes, easier to control blood pressure, easier to control dyslipidemia, but obesity and weight, very tough nut to crack. So I'm going to give you something to take home, I hope. So management, LSM, anti-diabetic surgery, drugs and surgery. So if you look at it, that the cornerstone of management continues to remain the same, with this lifestyle, pharmacotherapy, and then probably surgery wherever it's required. Evidence-based approaches, dietary therapy, physical activity, behavior is the only way. When we say mindful eating, there's a lot of cognitive behavior change we need to make. A lot of patient support system. As we have diabetes educators, we need obesity educators. These are the pharmacotherapy, orlistat, liraglutide, available in our country. SEMA not yet. The combination of naltrexone, bupropion, and phentermine, topiramate not yet approved. Weight loss, we have the adjustable gastric band. We have the laparoscopic gastric band. Then you have the gastric bypass as well. Now, when you talk about lifestyle intervention, what are we looking at? And what is the objective? Like we have an HbA1c less than 7 or 6.5. We are looking at least a 5% weight loss in 3 months. And intensive behavioral lifestyle change should include at least 16 sessions of counseling, which is approximately around 3 to 4 counseling sessions in 6 months, and focus on dietary changes and a 500 to 1000 kilocalorie deficit per day. That's the only way that you can achieve the target. And individuals' preference, motivation, circumstances, again have a huge variable in them achieving these kind of changes. Behavioral changes that create an energy deficit regardless of macronutrient composition will result in weight loss. Dietary recommendations should be individualized. For patients who achieve short-term weight loss, the long-term thing, which should be maintenance, should also have a lot of counseling sessions of at least 1 per month, and physical activity at least up to 200 minutes a week. Short-term dietary intervention using structured, maybe very low-caloric diet may be prescribed, but a long-term comprehensive weight management and counsel should be integrated. That is what the ADA also comes up with, that there should be integration of a short-term with a long-term plan, so that there is a good outcome at the end of it. What are the overview of the recommended behavioral changes? Obviously diet. Second is self-monitoring. We know, a lot of us know how to do self-monitoring of glucose or self-monitoring of blood pressure. But dietary recall, observing and recording caloric intake and other aspects of eating behavior. Anjana just spoke about the index. It is very prevalent. If you tell a patient to eat out in the whole city of Mumbai, I don't think he can find even one healthy outlet. So it's very difficult. It's a challenge for him on a day-to-day basis. Sleep management, physical activity of at least 150 minutes per week with 2 resistance exercise. And if you have to go up to moderate to at least 200 to 300 minutes a week, very easy to say, but stress management plays a huge role in this. Counseling, we're going to take this forward about what is all about counseling. Counseling is behavioral counseling, and it helps in a lot of ways. I'm not getting into details, but individually tailored interventions which include self-monitoring, a lot of social support, problem solving, a cognitive restructuring, slower eating, smaller portions, strategies for dealing with weight regain. A lot of community programs need to be inbuilt for kind of treating obesity as such. So what are the dietary modification? Of 500 to 1000 kilocalories should initially result in 0.5 to 1 kilogram per week weight loss. If you don't have more than 5% weight loss, because of whatever strategy in 3 months, we need to redesign the strategy. The higher the energy requirement is sometimes easier to create a restriction. Macronutrient composition may be less important, but greater initial weight loss with a lower carbohydrate intake is known. Mediterranean diets, I hope we lived in those areas, but is very, very helpful. And there are other alternatives to also low fat. Adherence is important. Most patients are unaware of the calorie density of food, difficult to control the calorie content of food outside. Patient preferences also matter. So Anjana did speak about this, the carbohydrate consumption. We know about this, 45 to 60%, fat 25 to 35%, replace saturated with unsaturated protein 15 to 35%. Now, this is what we need to actually stress upon. 150 minutes of walk or some form of aerobic activity per week can promote good amount of weight loss. If you have more than 300 per week, it can actually help in achieving more weight loss. At least 2 sessions of resistance training, engaging in leisure time activity is something that we actually never understand in urban life. Again, occupational or transportational exercise also, we do not have breaks even during conferences. So forget breaks in offices. Pharmacotherapy, again, there is a debate across the globe that whether we should just target HbA1c in people with diabetes or whether we should target weight loss. And if you look at all pharmacotherapy related trials in diabetes and obesity, it's very tough for patients with diabetes to lose weight. So whether you look at the scale, you look at STEP, the amount of the percentage of weight loss with people without diabetes can get, people with diabetes somehow are not able to get that. So weight loss medications are effective adjuncts to the cornerstone, which is diet, physical and behavioral modification. Pharmacotherapy for patients' response to weight loss is effective, defined as more than 5% weight loss after 3 months, then further weight loss is likely with the continued use. If that is not happening, then probably we need to reconsider what pharmacotherapy we are giving. We know SGLT2 and GLP-1 do help in weight loss in patients with diabetes. This is the scale study which was with liraglutide at the higher dosages, not in our country and not approved. Again, it caused a weight loss of 5.8%, which is much lower than the weight loss it achieved in people without diabetes. So even in the scale studies with liraglutide, people with diabetes were able to achieve just 5.8%. And after 56 weeks, you can see that the HbA1c again reduced by 1.1%. If you look at semaglutide studies, which is the step 2, where it compared 2.4 with the scheduled dose of which is used in diabetes, which is 1 milligram, you can see an impressive 9.6% drop with semaglutide as compared to placebo, and a 2.4-fold more patients on semaglutide achieved at least a weight reduction of 5%. Importantly, as the dose of GLP-1 goes up, the HbA1c reduction is not as good, but the weight loss obviously keeps getting better. These are the various anti-obesity medications approved by the FDA. If you look at it, you have the phentermine, unfortunately is not there, and fortunately I would say is not there. Orlistat there, but usage is very low, side effects are high. Topiramate is there, phentermine is not there. Liraglutide is there at a lower dosages, and higher dosages we hardly use. So there is a gap there as such. If you look at the anti-obesity medication and its role in diabetes prevention, 3 major studies of Zendol, Scale and Conquer, and also with, I have not added that, which is also Surmount with tirzepatide, you can see that the body weight change is anywhere between 5.8 kilos to 10 kilos with the combination of phentermine, topiramate. And again, the prevention or the prevention of progression of diabetes was better with liraglutide, almost close to 80%. If you look at Surmount, it's almost close to 90%. So GLP-1 seems to be coming up in the treatment and also in the prevention of diabetes and obesity. And very, very important line in the Surmount discussion was that in future also, maintenance of weight loss may also require pharmacotherapy. So today we may be using, or in future, we may be using pharmacotherapy for weight loss, acute weight loss, but probably when maintenance you may require it. If you look at anti-obesity drug and its effects on HbA1c, Obviously, liraglutide had a much better reduction in HbA1c as compared to orlistat or the other combinations. If you look at the mechanism of actions of the available FDA-approved anti-obesity drugs, orlistat, we know that it's a energy wastage. Oily stools is the problem with that, so you need to up-titrate very slowly. In India, we have the lower dosage as well. A good product if you use it wisely. Some parts of the world, it is also as an OTC product. Some parts of the world, you also have an alpha-glucosidase plus orlistat combination, again as an OTC product. People abuse it as a party pill. So you have these drugs, and probably you can use it and the up titration needs to be very, very careful with this. Liraglutide at that dosage is not available, is not yet approved in our country. Semaglutide is approved in our country, and it's an appetite suppressant. Now, if you look at the effect of the available anti-diabetic drugs that we have, we know that the GLP-1s and the SGLT2s help in weight loss, and DPP-4 and alpha-glucosidase are weight neutral. Insulin and SUs may cause a little bit of weight gain. So again, we know that in the last 1.5 to 2 decades, we know that high glucagon, or paradoxically high glucagon, is a defect in our people with diabetes, and incretin-based therapy, both oral DPP-4, oral GLP-1 and the injectable GLP-1 actually help in that program. If you look at the data from the Pioneer program, if you look at a good 1.5% reduction, you're going to have 2 studies coming at the ADA, which is the OASIS, which is on the oral semaglutide in people without diabetes at a dose of 50 milligram. You also have Pioneer Plus, which is on 7, 14 and 50 milligrams. 14, 25 and 50 milligram in people with diabetes and weight loss, both going to be presented at the ADA this year. And it's going to, the results, the top line are out, and it seems to be very effective. So probably you may have a labeling for this in the coming years as such. So targeted approach to weight management, 5 to 15% weight loss is beneficial in our people with diabetes. We need to look at all these things to improve the quality of life. Bariatric surgery, just giving a small snapshot of what we have. We have the gastric bypass, which a very long technical experience is required, partially reversible. As you can see, the stomach and small intestine are bypassed, and stomach is reduced to a very small pouch. Gastric band reversible, around 10% to 15% weight loss. Sleeve gastrectomy, which a lot of people call this as diabetes surgery or metabolic surgery, 10 to 15% weight loss, again an irreversible procedure. A little bit about cagrilintide, because that's going to, it's in a phase 2A program. Cagrilintide is an amylin analog, and you can see that the HbA1c reduction, when it's compared to semaglutide alone or cagrilintide alone, the combination has a fantastic HbA1c reduction. And the weight loss is also close to 15%. Phase 2A will go into phase 3. Maybe in the next few years, you may have all these drugs coming in. Tirzepatide, with its SURMOUNT studies, has shown that all the 3 dosages of 5, 10 and 15 cause close to 15%, 19 and 22% reduction in people with obesity and no diabetes. Again, in its studies on diabetes also, it has shown the same thing. So again, when we talk about weight management to our people, there's a lot of shared decision making, much more than that we do in diabetes. We need to be very, very empathetic. We need to take permission, talk to their patients about weight, because this is something which is culturally spoken at kitty parties and parties, and not in doctor's clinic. So understand the underlying causes, barriers, stigma, body shaming, so many things. So there needs to be a lot of empathetic counseling when we treat obesity. So set realistic goals. 5% in 3 months is realistic. Don't set the patient up for multiple cycles of failure. I would summarize saying that this an upstream approach can lead to early intervention in the treatment paradigm of diabetes and can reduce complication. Weight is given more importance in according to recent international and national guidelines. GLP-1 RA are a good class of molecules which addresses both. Recent advances present with combination could yield better results in both these and help in managing diabetes. Thank you all for a patient hearing.